Listening to podcast is no replacement for real training. While we attempt to provide accurate commentary, we hold no responsibility on how you use the information we provide. Get medical training. In the blink of an eye, everyday order can be replaced with once-in-a-lifetime chaos. Be prepared. This is the Civilian Medical Podcast.
Thanks for listening. This is episode 2. My name's Sean Heron from We Like Shooting and the Firearms Radio Network, and my co-host is the eponymous YouTuber, Dietrich the Skinny Medic.
Eponymous? What does that mean? What the heck did you call me?
Okay, Google, define eponymous.
Here's the definition of eponymous: of a person giving their name to something.
Okay, apparently I have no idea what it means either, but I'm pretty sure it's not an insult.
God, you're just using big words, man. Come on, man.
I'm just going to make them up, man. It doesn't matter.
Just start making up words now.
Latissimus dorsi? I don't know.
So today we're going to talk about the March algorithm and the phases of care that we should be working with.
All right, I love it. So we will deep dive into every single phase of care and kind of talk about that, but we're going to give a brief overview of just kind of what they mean, what it means to the people who are listening, and what it means kind of in real life situations, right?
Exactly.
All right, well, I guess let's dive right in. First phase of care, it's called two different things in two different protocols. I always go by direct threat phase, and you go by?
I go by care under fire.
All right, cool. But they're basically the exact same thing. So what is care under fire or direct threat?
So it means that you still have a bad guy shooting at you, or you're still in a really crappy situation. That there's still like this threat of danger that you can get hurt or I can get hurt, but there's still something really bad going on.
Yeah, and I mean it could be like if you're in a car accident, it could be all the things that surround you. If it's an active shooter, it could be the shooter, it could be other concealed carriers, it could be police, it could be kind of all of those things. But what kind of treatments do we do under direct threat?
So the only thing that we do is we stop major bleeding with a tourniquet. I mean, you're not going to be doing wound packing. You can hold some direct pressure if you need to, but you're not going to be putting on chest seals. You're not putting MPA in. You're not doing a blood pressure. You're not putting someone on oxygen, anything like that you may have. But this is just mainly what we focus on is putting a tourniquet on.
Right. And so what I always talk about is there's basically two fundamental principles of direct threat is A, gain the advantage over the threat, and B, consider that hemorrhage control as can be controlled by tourniquet.
Definitely. Always bring more friends to the fight. So if you're at your office complex or you're at your church or you're downtown and something bad happens, then you bring more friends to the fight. You put more gunfire than they have. So you can't do any of this cool, sexy trauma stuff until the threat's been eliminated.
Yeah, totally agree. I'm going to pause right there, 344. How deep should we go into it, do you think?
I don't know how deep, how much fully we, I don't.
Because I'm
we
like,
can talk about self-aid. Would you want to talk about self-aid there, or
should we do that like during the deep dive?
Yeah, I think we're fine. Because I think probably the March assessment is going to take a majority of the time.
Okay, cool. So 344 to. So do you think we're good on this one, or should we spend more time on it?
I think we're good.
Okay. 425-ish. All right. And again, we are going to completely deep dive into this. We'll talk about all the different things that are under direct threat phase and talk about some of the principles and protocols there. But then,
like right now, we're just giving that 3,000 foot mark, looking at a big broad spectrum of things right now.
Yeah. And I think probably next episode, we'll dig deep into direct threat or care under fire.
Exactly. I mean, there's plenty of things to talk about through, buddy aid, self-aid. So we could definitely spend some time thinking about it. So, but right now, just kind of looking at that big, like what's the big picture here to kind of help somebody.
Yep. Totally agree. All right. So the next phase of care is going to be?
We've got indirect threat or tactical field care.
Yeah. Just depending on it, whether you're TCCC or TECC again. And what are kind of the prime principles under that?
So this is where now the threat has been eliminated. Maybe we've moved to safety, whether that be a classroom, an office building, an office complex. We've kind of now is when we can see how bad our patient is, how sick our patient is. Just a little bit later on the podcast, we're going to talk about the March algorithm, and we're going to start doing that a good, solid assessment to figure out which patient is injured the worst, and how we can provide life-saving treatment to those patients.
Definitely. And we'll talk triage and kind of all that stuff as well. But again, just to kind of break it down into the fundamental factors is a reduced level of hazard and more in-depth medical interventions.
Exactly. I mean, you still may have a threat. So if you have someone that can help you pull security during this event, I would absolutely use them. If you're on the side of the road and you're at a car wreck, have some people like with flashlights or whatever they need to do to get drivers' attention to move them one lane over for you. I that was my fear. Like when I worked at the busy 911 system, was getting hit on the road. Like I did not want that to be the way I go out of this world. So
No.
blocking traffic, getting things. You've got bystanders standing around you who are just looking, who are gawking or whatever. Like have them go to work for you. Say, hey, I need you to stand there and wave your arms like jumping jacks like crazy and get people to move over. That way we don't get hit. If you're involved, whether there's been a threat like a office shooting, things like that, then have someone stand security at the door. And if bad guy wants to come back or someone else come back, like you at least have some warning there.
Yeah, I have an interesting anecdote, and I'm pretty sure I didn't tell this one in the first episode, but it was literally after I spent I think I had just finished my 5-day TCCC for medical practitioners course. And it was like just an amazing one. So I was like primed and ready, and I was, ready to help people. I was driving along the road. It was a very dark road on the way to my house late at night. And I actually watched a car get T-boned, and the SUV that got T-boned ended up on its side, with the dark side of the car, meaning the bottom of the car, actually facing oncoming traffic, which my big concern was, okay, well, any oncoming traffic, there's no street lights, there's no real light or anything. They're just going to come along and take out everything. So I stop the car, I get out of the car, and by the time I get there, there's a crew of 3 or 4 people that have kind of assembled on the light side of the car, so they can't see any oncoming traffic, and they've all put themselves into harm's way. And for me, this was absolute direct threat. Direct threat was that car. 2 people were standing right next to each other, both of them calling 911. So they were tying up the lines with 2 separate people. Another person was just kind of standing there, not really doing anything. And no one had talked to the lady inside the car. No one had even thought, oh, wow, there's just a dark side of a car showing up here. So if it hits us, we're all going to get taken out. So the first thing I did was try to take control of that, and just kind of like I tapped a guy on the shoulder. I was like, hey, man, they're already talking to 911. You probably don't both need to call, but if you could do me a favor and go around the other side of this car and just kind of stand there and wave your phone and your flashlight and just make sure that no one hits us, that would be great. And then once I had gained that advantage over the threat, I started talking to the lady in the car. Unfortunately, she was totally fine, and I didn't get to practice anything, but better luck next time.
That's why I've been on several instances where like fire trucks have gotten hit or an ambulance got hit because people aren't paying attention. They're just either one, they're looking at their phones, or they're trying to see what's going on with the wreck, and they're not paying attention to what's in front of them, and they rear end a car behind them, or they've hit the fire truck, or they've hit my ambulance. So being on the road is a bad place to be. Like you said, at night, things like that. If it's raining, the interstate where there's 4 lanes, people are running 80 miles an hour. It's a bad spot to be in, and it's a scary spot to be in. It can be a scary spot to be in. So, you've got people standing around, put them to work.
Yeah, I totally agree. And it's crazy. People are all concerned about, the automatic self-driving cars and stuff. I'm like, well, since cell phones were invented, everyone's pretty much driving a self-driving car these days. As long as there's no stops or anything out of the ordinary, everyone just kind of coasts along and doesn't really pay attention.
God, people like texting, reading books, the newspapers. I'm like, this is ridiculous. Like, it's scary, some of the stuff we've seen.
Couldn't agree more. All right, so again, we'll dig deeper into indirect threat and tactical field care in a later episode. Probably episode 4 is my guess. And the final one, what are those? What is that?
This is where tactical evaluation. I can't say it. Hold on. Sorry, edit that one out.
Okay, hold on.
Sorry about that. I was like, it was
No
not going to
problem.
come out right.
No problem. All right. You are good to go.
All right. So our last phase of care that we're thinking about is evacuation or tactical evac.
Yes.
And this is where we're going to start moving patients. And this is where you wish you put that extra mile of cardio in. Like, this is where you're like, man, I should probably start going to the gym.
I totally agree. This is the play in every class I've ever been in. This is the place where people injure themselves, and back injuries are the most common because without question, every class I've been in, there's always a dude that weighs like 400 pounds and is built out of like dark matter, and I always end up having to like drag him 25 yards or something like that.
Oh my gosh. And like for my civilian classes, like we don't necessarily tell them to bring vests or anything like that. So, we do work on patient movement. And now I'm like, now think about like if you were in a tactical situation where you've got a vest on, you've got a rifle slung across you, like you're adding an extra 25 pounds to you at least. Now you got to move this guy who weighs 250 pounds. Like it smokes you so fast. And like for me, being in tactical medicine, being attached to a SWAT team, like I feel like the medicine part is easy for me. Like I live, I breathe it. It's easy. This is a part now. I'm like, holy cow! Like this smokes me trying to move these dudes that like just want to kick in doors for a living, and now I've got to try to drag them down a hallway, move them out the door. Like it is taxing on your body very quickly.
Yeah, I agree. So for me, I spend most of my time talking about evacuation. I'm like, okay, the reality of the situation is, you're a 60-year-old woman and like I can literally see that it hurts you to pick up a bottle of water or something like that. So you're not going to be dragging people. So how do you get people to move themselves? How do you plan for when the first responders actually show up? Just kind of all that stuff. If you do have to move someone a little bit, how do you move them without injuring them further? Because that's the key of evacuation, right? Is get them to the next level of care and don't cause further injury to your casualty or yourself.
Right. When I think about patient movement, one of the pictures I show in my class is if you Google Virginia Tech school shooting, like there's going to be a picture that pops up. It's a grassy knoll. There's 4 cops carrying one teenage kid. He's probably a young adult. And they're like, one cop has an arm, the other one has another arm, another leg. Like 4 people are carrying one patient. And it doesn't look good for the camera. It's not good for the patient. Like you're hurting them. So, like I always talk about the drunk fireman carry, like that's not it. The drunk carry is, you got one on each arm and you can take somebody and walk them to their car or walk them to wherever by just putting their hand over your shoulder and assisting them to wherever you need them to be.
Mm-hmm. Yeah. And I also focus on, if you have to move somebody downstairs, don't take them feet first.
Boom, boom, boom. Just push them down. They'll be fine.
Exactly. It's no big deal. All right. So
I always laugh about the fireman's carry. Like nobody does fireman's carry. Not even firefighters. They don't do fireman's carry anymore. Like nobody does that.
No. And have you seen the one where they like grab a leg and then kind of do a tuck and roll over the person, come out on the other side, lift it up in a fireman's carry? Come on.
Yeah, we should do that next time we see each other. We'll get that on video. Like we'll tuck and roll and try to lift up Jeremy. Like it'll be fun.
That sounds terrible, but I'm totally.
Like thinking about like evac too, you've got to start building patients together, like we call them casualty collection points.
Mm-hmm.
And this is where you are, bringing all the injured people to one centralized location. Because when EMS gets there, if say you only have 2 people hurt or 3 people hurt, or you have 45 patients hurt, the more you can get them organized, the better you're going to help EMS figure out what's going on. And if you're going to be there for a while, with an active shooter, I kind of tend to focus on that, is you're going to be on your own for a while because EMS is going to take them a while to get in there, to get moving. The police officers are coming. Their goal is to go shoot the bad guy in the face. So they're running and they're part of security. And meanwhile, you're trying to stop your friend from bleeding to death. Mm-hmm. So you're going to be on your own. So if you can move these patients closer together, it helps you as a responder to provide better care because you're not running from one corner to the next corner down the hallway. Bring them all together. Like make it easier on you to treat the most people if you've got them right there beside you.
Yeah, totally. All right. So those are the 3 things that we'll be deep diving in on the next couple episodes. And then now let's actually start to we told them the algorithm of March last episode. Let's actually start moving through it in this episode and just kind of talking briefly about each fundamentally. And then we'll really dig down in future episodes as well. Again, we're trying to set up the foundation now so that we can actually teach the skills in detail later.
Definitely. So March, we have massive bleeding. And then once we get all the massive bleeding taken care of, we're going to move on to airway. And we'll talk about that in a second. And then you've got respiratory, circulation, head injuries, and heat loss.
Definitely. All right. So first off, I mean, let's start out with what is massive bleeding. Like to someone who's not been around a lot of blood or seen blood or seen how it pools or anything, like what is massive bleeding? And I know you've got some really good videos on this, but I think you have a really good explanation.
Yeah, I mean, like we see in movies of like blood squirting everywhere on the ceiling and the hallways and all this blood spatter, and that happens. Not saying it doesn't happen, but typically that's not the way this plays out in real life. In real life, their blue jeans catch the spraying blood, so their blue jeans are soaked in blood. They're laying on the ground, and now the blue jeans are full, and now you have this large pool of blood that just keeps getting bigger, bigger, and bigger. So it's not this massive spray like rainbow of blood coming out of the leg. Like it's not that. That's not how it's going to present. So people tend to downplay it. They're like, "Oh, this isn't a massive bleeding," but yet the blue jeans are soaked in blood, and they're having their feet are in the blood. They're just trying to lean over the patient, and they're like, "Oh, it's okay. This isn't a lot of blood." And looking back, you're like, "Yeah, that was a lot of blood that they were trying to tell you. You just missed it." And one of the things we always teach is that, I have a tendency to just go straight tourniquet. Like, all right, that's a lot of blood. Let's just put a tourniquet on it. But you really probably should be holding good, solid, direct pressure on these wounds to try and get the bleeding to stop.
Yeah, 100%. Direct pressure, even when I'm putting my gloves on or preparing to put on a tourniquet, something like that, I try to get my knee on it to at least get, or depending on where it is, try to get my knee in a pressure point to stop that, or at least slow it down while I get my gloves on and my biological barriers and whatever happens. Because every drop of blood is important. What is it? 5 liters of blood in the human body? Five.
Yes. Average. Yep.
Is the average. And you do have some videos. I highly recommend people look up Skinny Medic and go look at the videos about kind of what is a heavy bleed. So the reason that massive hemorrhage is so important is because how long does it take to bleed out?
About 3 minutes with a femoral artery, you can bleed out that entire 5 liters. And then in about a minute and a half, you've lost half your blood volume, and you're probably starting to go unconscious, semi-conscious. You're not able to make decisions. Like you can't physically make your hands do what you want them to do in about a minute and a half-ish.
Yeah, and and depending on where you get hit. So there was that video of a guy and a girl walking down the street, and there's a guy standing up on a couple stairs leading to
Oh, yeah.
and it looks like the girl goes up to grab him, pulls him down. It looks like her partner actually has a gun, and I think is the way it finally laid down. And he tries to shoot the guy, but ends up hitting her instead. The guy that they attacked runs away. She takes like 3 steps up onto a stair. You see blood spraying, and she instantly collapsed. I mean, it is less than 10 seconds, and she is down and unable to do anything.
Yeah, like it's a hard one to see, like where she got hit. I mean, I read some of the police reports on that, and it looked like she got hit in the stomach, which would have probably hit like a major descending artery in the abdomen. That thing is massive. She was dead before she even hit the ground, and that was a great footage. I was like, holy cow! Like that was good stuff.
Yeah, and there's another one, some third world country where a guy's yelling at a guy in a military uniform with an AK, and the guy in the military uniform, after a couple of minutes, has enough and just points the gun at his leg, shoots him. And this guy is within 60 seconds, he's on the ground. Within 90 seconds, he's no longer moving. It's just that fast. So really controlling that life-threatening hemorrhage is absolutely number one medical priority. Whether teacher,
right, because
ECG,
we're not carrying red blood cells, anything like that with us. We're not carrying packed red blood cells, so we've got to be able to keep all that inside the container. You were talking about like putting a knee down. Like I teach, like to put a knee into the love crease.
Mm-hmm.
Like when you stand in the mirror, you look at yourself, like you got a love crease runs right down your pelvis. Like if it's a bleeding the leg, slide that knee right into that love crease and put some pressure on to slow down that bleeding.
Yep, absolutely. That gives you at least a couple more seconds to get gloves on and protect yourself. Um, when I talk about massive hemorrhage, we'll talk in the future about golden hour and that platinum 10 first minutes, because I think that's important just to kind of discuss. But we'll save that for the deep dive. But massive hemorrhage, that is the one thing under the direct threat care under fire that you actually consider treating. And that's if you can use a tourniquet, because you don't have time for direct pressure. You don't have time for wound packing. It's if I can tourniquet it to save their life, I might do that under direct threat.
Definitely. And we talked about in the first episode, in our first episode we did, was the gentleman who's got the partial amputation to his leg or
Yeah.
to his arm. And I said that absolutely I would put a tourniquet on that. Even though we don't see that massive bleeding for this, I would bet good money that he's got vasospasms, that he is constricting the blood flow, and he's going to relax, and then that blood's going to start flowing. The other thing that you'll see sometimes is the fact that these patients have already bled out so much that their blood pressure's low. Instead of being 120/80, it's now 70/30, and they don't have the pressure to spray anymore. So you just have oozing blood, but it's an arterial bleed. It's just the pressure in the system is so low that it's not spraying anymore.
Yeah, so crazy, so crazy. And then as far as massive hemorrhage goes, we talk about tourniquets, and there's so many tourniquets on the market.
God, they are flooding the market right now, and I like it. I think there is no perfect tourniquet on the market. For me, I think the Cat's probably darn near close to it. But there's some things that I really like. I like the fact that the Sam XT clicks. When you pull that initial band tight, it clicks. I'm like, that's nice, especially teaching civilians at like a church or an office complex. If I can say, pull that band till it clicks, it gives them that audible feedback. So I think there's room in the market, but you got to beat the king. And I think the king is the Cat right now.
Yeah.
The Soft T is another good one. But for one-handed application, the Soft T is still a struggle. It has gotten better with the new Gen 4. Like we talked about in the first episode, that it's got the track system now, so it's a little bit easier getting into the windlass to lock into place, but it is still tough.
Yeah, I agree. And by the way, I ordered one of those from Medical Gear Outfitters while we were doing the show, and it shipped that day, and it got there. I can't remember if it was the day after afternoon or very early in the morning the following day. So it was like less than 48 hours.
Nice. I like
Which
it when I hear
is-
stuff like that.
Yep. So we are going to continue to go through these tourniquets in detail in kind of in our product segment. But what about improvised tourniquets?
If we look at like the Boston City Marathon bombing, like that dude jumped around and he was just making tourniquets. Now we look at those, probably were more like good pressure bandages, but they still worked. So the old, like using a t-shirt, using a stick, and having a windlass, windlass being something hard that we can rotate to gain the advantage on it. Those work. It's just that for me wouldn't be my plan A. Like I wouldn't go around this world thinking I'm just going to make a tourniquet. If I was at the range, that wouldn't be my plan A. Is go, oh, if something happens and that dude shoots himself in the leg, I'm going to go get his t-shirt and a wrench and make a tourniquet. Like that wouldn't be my plan A.
Mm-hmm. Yeah, I totally. I mean, have people been saved with improvised tourniquets? Absolutely. Do I want someone using an improvised tourniquet or a Gen 7 Cat tourniquet on me? A Gen 7 Cat tourniquet, clearly. I mean, I'm not saying it's the only option. I'm just saying, if you can, why not? How much is your life or your friend's life or your family's life worth?
Exactly. And if you're going to make an improvised tourniquet, just make sure it's nice and wide. That the wider the tourniquet, the easier it is to get that muscle mass to collapse around, and it's a lot easier. You start getting narrower, it takes more pressure, and it gets tougher. So, not saying you can't do it. I would always. It's another tool in the toolbox.
Yeah.
It's know how to do them, know how to think about them. But that wouldn't be my plan A. But if I only keep a few Cats in my truck, so something bad happens, I'm gonna start using t-shirts, whatever I can use to improvise to start making tourniquets in a bad situation when I run out of them.
Yep. What if you don't have a tourniquet? What if you don't have anything that you think you can make a tourniquet out of? Is wound packing an option?
Yeah, like I think that's a great option, is to start putting gauze down into the source of the bleeding. whether you've got just a major, huge laceration to the leg, start putting gauze. Like it can be whatever material. It could be a t-shirt, a pillow, whatever you need to do, bed sheets, whatever to grab and start. I wouldn't use like a greasy like shop rag if I had to, my choice, but just a clean cloth that you can put in there. It doesn't have to be super clean because they give antibiotics at the hospital, but you got to keep that red stuff on the inside.
100%. Let's move into wound packing. What I always heard that tampons were the best thing for wound packing.
Oh my gosh, you're gonna give me a migraine. You're gonna give me a headache.
I know. I just gave myself one. I can't even believe I actually said that out loud. But I
Oh my gosh, that
do not.
like, my face is turning red now. Just think about it.
I know. That's why I did it.
I will get torqued.
I know.
That and you buy a Chinese knockoff cat, man, you'll be good to go.
Yeah, exactly. No problem whatsoever. So to be clear, tampons never good for stopping bleeding or wound packing. There's excellent definitive videos out there. And I know Skinny Medic even has done videos on this topic in detail talking about it.
I always tell guys, I'm like, all right, first of all, a couple of things. When you are in a trauma class and you pull out a tampon, dudes get really uncomfortable quick. They're like, what is this guy doing? He is holding a tampon in his hand. He is like messing with it. That's weird. That's awkward. And like the girls start giggling. Like they think it's hilarious. So, but I always tell guys, I'm like, dude, next time you're there taking a crap, open up the cabinet, get your wife's tampon out, open it up, and look at how much gauze is not there. I'm like, you can see there's clearly not gauze there. And I'm like, throw it in the trash can. Your wife's never going to know you were playing with her tampon. And it gets some education while you're pooping.
Yeah. I mean, use that time wisely, I think is definitely a good thing. So tampons are not good because we're not trying to sop up the blood. We're not trying to absorb blood. We are trying to stop the bleed. There's not enough material there. It's not going to help induce the clots. It's just going to get soaked and you're just going to basically do nothing. So
Right.
don't do that. But can other things be used for wound packing? Like what if you don't have gauze or hemostatic gauze?
Yeah, I mean, absolutely. You could take someone's t-shirt and put it down into the wound and hold pressure. Now you're gonna have to hold pressure for a while because you're just using regular gauze and you're trying to let that clot build up. But yes, you can use a towel, a sheet, whatever you need to put down in there. Even when I took a basic first aid class years ago, when I took EMT, wound packing was not a thing. Like we were not supposed to do that. So like, all right, we're just gonna put this gauze on top, and while it's on top, it's just bleeding underneath. So you can use whatever you need to, just make sure it's getting down into the wound and you're able to get it to the source of bleeding. Now, I would probably ask the patient's name before you start sticking your finger into their pelvis to stop the bleeding.
Mm-hmm.
But, definitely introduce yourself before you start pulling their shirt off and shoving stuff into their wounds.
Yeah. So when we talk about building IFACs and things like that, I don't want to speak for you. I always recommend gauze, like acrylic style gauze, compressed Kerlix, whatever, but also hemostatic gauze. Why don't you run us through those two things?
So yeah, the same way. Like if I went and could show you guys my vest that I use for the SWAT team, like it has some compressed gauze and it has combat gauze in it. My combat gauze is going to be used for the initial wound to go inside, to go to the source of the bleeding. And then if I need to backfill it to use as in to get that mound, to get the back side of the wound filled, I'll use the compressed gauze because I don't really need the hemostatic agent there. I'm just looking for bulk. But there's two main players of hemostatics on the market right now. And there's a couple others that are coming along, but two of the major ones are Celox and combat gauze. You've got Celox is the primary one here in the US that's the most popular. And then over in the UK, you've got Celox. Celox is going to be made of shrimp shells, basically. And they take I think it's iodine, to take it out of it. So you don't have to worry about any allergies, things like that. And they use that and it works well. And then combat gauze is made out of like a rock material, basically. And it does the same thing. Combat gauze basically takes the water out of the blood, makes it thicker, and that's what helps with the clotting process. Celox does like a positive negative ion, which is way above my head. It's chemistry stuff, but that's how it controls bleeding. And if you can afford it, I mean, those stuff it's expensive, and I get it. But, those things help you tremendously as far as wound packing. Technique is a big part of it, but those hemostatics really do help. But you've got some more that are coming on the market, like the Kaito gauze, stuff like that's got some antibiotics already in it. There's some new stuff coming on there as well.
Very cool. So you get the wound packed, you get direct pressure on there for 3 minutes, and then what comes after that?
So yeah, I mean, you with the hemostatic agent, you're holding pressure for 3 minutes. If you're just using regular gauze, you got to hold pressure for 10 minutes. So it's a lot longer that you're holding pressure in here, and that you're just looking for any kind of bleeding around there. But after you've held pressure, then you got to make sure everything stays in place. So you need a pressure bandage to hold all that gauze inside there.
Yep, exactly. And there's all kinds of those as well.
Man, there's a buttload of them, aren't there?
Yeah, there's Israeli style, the wound stop. There's just there's tons of them. Like, what do you recommend? What do you use, and kind of what do you sell the most of?
So the Israeli, the emergency bandage is our most popular one. That's our best selling by far. The 6-inch, the standard one, is our best seller. Probably followed by the T3 bandage, which is they're made by the same company. It's a 4-inch, but it also has some wound packing gauze with it, which is a pretty cool feature. It's a 4-inch bandage, and then in the same package, you open it up and you have some wound packing gauze in there. It's non-hemostatic. It's just regular cheesecloth, but it still works. So you have everything you need in one package. The next one is the Elias bandage.
Mhm.
That's a great bandage there as well, because you've got the wound packing gauze in it as well. It also comes with a piece of plastic that you can make an improvised chest seal with. That's a good one. The H bandage, man, those things, I like those just for the packaging. They're so thin. You know, the Israeli doesn't take up that much room. The Elias takes up a little bit more room. But those H bandages, they're so flat. You know, they're not much thicker than your iPhone, a little
Yeah.
bit wider than your iPhone, but as far as thickness, they're about the same size thickness as an iPhone. And for someone who is looking to put something in a day pack, or something like they're going to put in a backpack for their everyday carry, that H bandage is a great choice. For me, I keep the Israeli in my vest, and then I keep an Elias in my backpack because I have more room in the backpack. So I keep that there, and then I keep the Israeli inside my vest.
Very nice. I like that. All right. So that's kind of the stuff under massive hemorrhage. We discussed a little bit about what is massive hemorrhaging, and then some of the different things that we'll dig down deeper to. I know I keep saying that a lot. And again, this is a podcast. We're also trying to teach you some stuff. So we're going to keep introducing concepts and then digging down into those concepts. But I want to take a brief moment, and just want to remind everybody, what does MARCH stand for? Massive bleeding, airway, respiration, circulation, and hypothermia and head injury. So pause the podcast, repeat that to yourself, and then we're going to do it again in just a minute. So the next thing that will kill you the fastest in these kind of injuries and situations is going to be airway. Why don't you kind of tell us how quickly not having an airway will take you out?
Right. So like we talked about with massive bleeding, that 3-minute mark ish is where we're at. Now with airway, we got 6 to 8 minutes. So we have a little bit more time that you can go without breathing, and not having an airway, that you start getting some death to the brain cells, things like that. So that's why we control the bleeding, because we got 3 minutes there, but we have a little bit longer with airway.
Yeah, definitely. What is airway? Because there's airway, and then there's also respiration or respiratory. Explain to us kind of what is airway.
Yeah, so when I think about airway, I think about the mouth, the nose, the jaw, like that upper portion. And then we're going to move on in a second to respiratory. That's the chest, like that's the thoracic part of the body. That's even you can even get down to the abdomen area, because I've seen patients that got shot in the stomach and they hit the diaphragm. So anything in like the torso is more respiratory. And then airway is like the nose, mouth, face, and like how can we fix this so they're not snoring? If you have someone who is unconscious and they're snoring, I promise you they're not sleeping. We need to fix that.
Yeah, definitely. All right. So in airway, I always say that your airway, if your airway is not open, respiration doesn't even matter, right? So you have to make sure that your airway is open, and then you worry about actually using that airway.
Exactly.
We'll go deeper into this as well, but there's a bunch of different stuff that you can do to kind of help with an airway. The most basic and the kind of the first one that I always teach is just literally the recovery position.
Yeah, I mean, start simple. Whether that be the recovery position or even thinking about like a jaw thrust, a head tilt chin lift. But let's start with something simple before we go haywire with this.
Yeah, totally agree. So I teach recovery position, and then I teach jaw thrust, and chin lift separately. And then, of course, there's our favorite, the nose trumpet, the nasal pharyngeal airway, or the NPA.
Yeah, and this is the one that's pretty easy to put in. I mean, there's some difficulties, but with practice, it's not a big deal. I always talk about people giving the pig nose, and like that's the easiest way to describe it, is to give your patient a pig nose and slide it down in there, like lubricate it. Hopefully, you get some lube for it.
Yeah.
But slide it down in there. There's other airway adjuncts, like you think with the OPA, which is like the hard J-looking plastic. But if your patient's kind of semi-conscious, they can still have an intact gag reflex. And like my gag reflex starts by my lips. Anything past my lips, I start to gag. So, that would be one cautious. But in MPA, if we could hold one of us down, we could put an MPA in right now.
Oh yeah. In my classes, like I teach a lot of listeners if we like shooting in the classes, and I've always got somebody volunteer for an MPA. So
yeah, like every class, somebody's like some little kid, like I say little kid, like little 21, 22-year-old come to class, goes, I'll do it.
yeah.
Okay. You might, I'll clean your sinuses out for a little bit.
No,
And the one thing we talk about with the MPAs is the, like the head injuries. Like, and every time I post something about airway, whether on YouTube or Facebook, someone's like, you can't put an MPA in that. And it's because they've got head trauma. And they think about, oh, it's going to make the curl, it's going to go into the brain. And it's not true. It's one of those myths that we heard from one person, and then we spread it, and then it keeps spreading, and it's just not true.
Yeah, generally I use a flashlight look at the upper part of the palate, and as long as there's no real trauma to that part, then I definitely have no problem putting an MPA in.
Right. And for those major facial traumas, there's only been 2 instances that I can recall seeing in literature, and one was NG tube. So it wasn't even MPA. It was NG tube is what they put down, and it's really a longer tube, it's more flexible. It's supposed to go down to the stomach. It did. Like they inserted it curled back up, went to the back of the brain, and that guy died. But he was probably going to die anyway. But that's beside the point. But so for all the stuff that we're doing research-based medicine or pulling this literature out, it just doesn't support it. So I still say if someone's got major facial trauma and they're snoring and you need that airway, put the MPA in. Like do it right, like you say. Whether you're looking at the hard palate, take a look at it. Use some you do some examining and look at it, and then insert the MPA. It'll be fine.
Yeah. All right. So, and again, we'll teach people how to put in MPAs. It's actually super easy. It's something you can totally verbally just tell them how to do when we dig deeper. You've got listed in the show notes suction.
Yeah, this is one of the things that people a lot don't think about putting in their trauma kits is some sort of suction. And you can buy the high-speed tactical one, but all it is a turkey baster. So I usually tell guys, look, you can buy it from me if you want to, but like I would save money and go to Walmart, buy a turkey baster, trim it just a little bit because the tip of the turkey baster is pretty small. Bring it up a little bit. That makes a great suction device. Now, like you were saying, if you do turn someone into recovery position, that vomit, that blood, that tooth, whatever is probably going to come out. But having that turkey baster makes it a lot easier to suction and clean out that blood, that missing tooth they've got, or whatever's in their airway that's not supposed to be there. We can clear it out for them. And even thinking about like if you're at the restaurant, someone's choking and they go unconscious, and we start this whole big ordeal going through that. If you can use a turkey baster to get the piece of steak out of their mouth, that's going to help them. So adding a turkey baster to your trauma kit is something you might want to think about.
That's pretty awesome. Adding a note. I love it. What else do we have in airway? I think we've just about briefly touched on the stuff that we're gonna really dial down later.
Yeah, we've got position, use an airway adjunct, suction, clear it, and go that route. So if you do all of that, you're gonna have the airway clear, and you're able to move forward to the next step.
So what if we've considered chin lift, jaw thrust, recovery position, and nasopharyngeal airway or NPA? What can we do if none of those things work?
You can do a surgical crike. I mean, I could do a surgical crike. That's one of those things where I wouldn't recommend like our listeners like doing that, pulling out your MacGyver scalpel and cutting this guy's throat. I probably wouldn't recommend that, but it is an option. I've never had the opportunity to do it in real life. I've trained, I've cut on cadavers, I've cut on mannequins, but I've never had the chance to do it, and I hope I never. Honestly, it's one of those things
Yeah.
where once in a career opportunity, but that's like a last ditch effort. And for our listeners, that's not going to cover you on the Good Samaritan law. Listen to what I just said. So don't just ignore that last 30 seconds. But
Yeah,
know,
don't- but it is out there,
Yeah.
the cricothyroidotomy, and it's intense, man. This is not something that normal people are out there going and doing. And like you just heard Dietrich say, he's trained, he's done a lot of different stuff. I did it on a pig. I could tell you the steps and just basically recite, but it's so much different on actual tissue and stuff that it's bad news.
definitely.
All right.
I've had some training in like special forces dudes that have done it a lot in the field. In the military, it's not as big a deal as we think about it, pre-hospital and civilian market. But those guys are jam up at it. And I'm like, this is weird. Like you're cutting someone's throat. The carotid arteries are running right there. This is a big deal. So, I haven't had the opportunity to do it yet. So hopefully never happens. But like I said, I've pigs before. We've done cadavers, dead bodies who have, people who have donated their body to science. We're able to use it, things like that. So very cool. But I carry a kit in my SWAT gear that I can use. Hopefully, I never it just expires and goes away.
Yes, absolutely. All right. So taking a brief pause, we're going to remind you what March stands for. And again, that's massive bleeding, airway, respiration, circulation, and hypothermia and head injury. Which brings us to respiration. Once we've stopped that massive bleed, once we've made sure and done some remediation that they have an open airway, respiration and respiratory is next. Talk about that.
Respiratory rate one is, if there's any holes inside the chest, we need to fix it. We need to put a seal, a commercial chest seal like Hyphen or Halo or any other commercial chest seal. We can use that. And we can make one out of a plastic bag or even just a gloved hand on this is going to help seal it. And what the problem comes in is if the hole really needs to be 3/4 size of the trachea before we get that true sucking chest wound. This is where you see like bubbles coming up, things like that. Air is going to take the path of least resistance. So if it's still least resistant, it comes in and out of the trachea, then it's going to do that. And it's not a huge deal as of right now. It may develop later, but for now it's not a huge deal. But when you get a large hole and now air is coming in and out of the thoracic cavity, the chest wall, then air is not going in and out of the lungs properly, going to suffocate very quickly if you don't fix this problem.
Yeah. So progressive respiratory distress is kind of what is considered respiratory problems, things like that. That's caused by a pneumothorax, a tension pneumothorax, that open pneumothorax or that sucking chest wound. And we will, again, talk about this stuff in more detail. But basically, if you have penetrating trauma to the chest, and that's basically belly button to collarbone, 360 degrees around, you seal that box, right?
Yeah, what we talk about is neck to nuts. Anything from neck to nuts, you just seal it up. And that's like I was saying earlier, like I've seen anything like you were talking about the belly button. The belly button, I've seen like somebody get shot with a small caliber and it goes into the stomach and all of a sudden having respiratory distress. And you're like, why is this guy having so much trouble breathing? And then when you get to the hospital, you get an X-ray, and you're like, oh, it got his diaphragm, it bounced up, and his diaphragm. That's why my patient was having trouble breathing. He was hypoxic, So those bullets, just because we see it where we thought it went in, we have no idea where it's gone after it enters the body. So, unless neck to nuts, whatever you want to say. I'm gonna have a T-shirt made, just like
I like
Love
that.
Priest, neck to nuts, like have all this stuff going on. But put a chest seal on it, and don't forget that the lungs are on the back side. I've seen plenty of people go, oh yeah, I just put chest seals, on top of the chest. And we're like, but what about that exit wound coming out of the scapula, like the shoulder blades? Like, let's put a chest seal on there too. Let's log roll the patient, roll them up, and just double check we're not missing something on the backside.
There's definitely a reason that they come in packs of 2.
Yes, absolutely.
Lots of chest seals, and we will go over those kind of products, but it's a sticker. You open it up, it's a sticker. Like anything can be a chest seal. A Walmart bag, the packaging from actual chest seals, like your hand, your gloved hand, can work in a pinch. But yeah, all kinds of things can be used as chest seals. It's just really stopping any air from getting into that system, that thoracic cavity.
And for us, I think this is a big deal because the military, the police officers, they're wearing a bulletproof vest. So we see a lot more like extremity, arm and leg. But for us, like I don't typically wear to the BI-LO to get groceries.
Yeah.
If I'm teaching, I'm typically not wearing my level 4 plate carrier vest ready to go. That just the students would laugh. And but these chest traumas, we're seeing a lot of those, and whether it be an active shooter, active threats, bombings, whatever, there's a lot of chest trauma. So we do kind of focus on major bleeding and tourniquets, but you got to progress quickly and make sure there's no trauma to the chest area.
Yeah, in my classes. So actually, I mean, massive hemorrhage is the wounding epidemiology that kills most of our soldiers overseas and things like that. So that's really what TCCC focuses on so much. And again, like, major bleeds will kill you the fastest. But when I looked at that, again, to use that big word, wounding epidemiology, meaning the places that people were injured in active shooter situations, active killer situations, and things like that, a lot of people were dying from being hit in the chest and head, more so than being hit in the appendages and, the brachial and the radial arteries and that femoral artery that goes down through the groin and into the legs. Like that was less common in these civilian incidents. So I started to put more focus on respiratory. Unfortunately, besides sealing it up, there's not a ton that we as civilians can do. Would you agree?
Right. I mean, basically you seal it up and you let God take care of it. I mean, that's the way we teach it. I mean, I hate to say it, but that's what we do. Like we seal it up and you let God take care of it. Like he's going to take care of it one way or the other. So, and like you said, if you look at these after action reports from the school shootings, the church shootings, they're all, like you said, they're chest and head, point blank. So, and I agree, like, working around chainsaws and stuff like that, we focus heavily on tourniquets, but the next flip, we're right back heavy on the chest seals and really doing a good solid exam on that chest to make sure you're not missing anything that could be life-threatening.
Totally agree. So you've got in here the BVM. I actually don't carry one of these. Talk about why you do.
So I do. I carry one. So patients are supposed to breathe about 16, 18 times a minute. If everything is cool, everything is fine. We're probably breathing about 16 times a minute right now doing this podcast. But when you get severely injured, that can slow down. It can go, say, less than 8 times a minute, and that is not effective breathing. So your patient still can have a pulse, their heart is still beating, but for whatever reason, they're not breathing, whether that's a gunshot wound to the chest or whatever's causing them to be on heroin or whatever the problem is. So being able to assist them in their breathing can be beneficial. So that there again takes some training, takes a little bit of practice. But using a BVM to squeeze it's a mask that goes onto their face. You have another bag out to the side of it that you squeeze. You squeeze just enough to get chest rise, count to about 6 seconds or 8 seconds ish, somewhere around there, and squeeze the bag again until you get chest rise. And you keep doing that until help comes. But especially like opioid overdoses right now being so rampant, and that's a huge problem. So with overdoses, we go off of trauma just for a second. I'll kind of scroll off for a second, but with overdoses like heroin, fentanyl, and stuff like that, these patients are not breathing. They still have a good blood pressure. They have a pulse. They're just not breathing. So if we don't have Narcan, then we can use a BVM to do that. And I'm not doing mouth to mouth. That's nasty. So using a BVM helps that process. So if you have a patient who's been shot 4 times in the chest, but they don't have any bleeding externally, but they're not breathing, they're only breathing 4 to 6 times a minute, well, let's pull the BVM out, assist them until help gets there. Help by that time until they get to surgery.
All right. I like it. Anything else to cover under respiration?
Not that I can think of.
Yeah, me either. All right. And again, we'll go through it. And some of this information we are going to repeat, but we are going to dig down and kind of just go through the stuff in as much detail as we possibly can. We're going to do kind of one thing per. So after respiration, again, I want to remind you, March stands for Dietrich. This time you get to go.
So we've got massive bleeding, airway, respiratory, circulation, head injury, or heat loss.
All right, perfect. So
I think it is important just to keep repeating this. It's important to keep repeating it because this podcast is for the average person who may be in the firearms, or maybe they're out being outdoors, so they're little trauma stuff every single day of their life. Hopefully not. So the repetitiveness, the more we can repeat it, the more we work on. So you're like, oh yeah, I do remember what those guys said. So I think it's absolutely very important that you keep repeating it.
Yeah, in my classes, it's like I start at the beginning and I'm constantly just quizzing people. Pretty much every time I pause to change subjects, topics, thoughts, whatever, I go through and ask people kind of what it means and what are the phases of care, just so they actually do remember it. Because once you get into the scenarios, in the practical scenarios of this stuff, it's funny how many people forget how to spell a 5-letter word.
Under stress, they freak out.
It's so true, and I have people what comes next? I mean, and I think that the repetition kind of helps really drill that in. So that's why I do it. Circulation in TCCC, circulation is really just assessing the patient for shock. And in this case, specifically hemorrhagic shock, which is the loss of blood in the system. Would you agree?
Definitely. It's kind of we have to kind of tweak it for our viewers now. We have to kind of tweak that a little bit because for me, like in the field, this is where I'm doing vital signs. I'm checking on blood pressure. I'm going to do a more detailed exam. If I have the ability to give some blood products like whole blood, stuff like that, then I'm going to start hanging whole blood and kind of going that route. But I'm not sure what you teach in your classes, but in my classes, this is where we do a detailed exam. And, if someone has a blood pressure cuff, absolutely throw it on, get a set of vital signs. Like I teach my students how to take vitals. So while you're just waiting on EMS to get there, you're kind of killing time while you're trying to look busy, then take a blood pressure. But ultimately, this is where I check, all right, guys, you've kind of made it through MAR, go back because paramedics miss them, doctors miss them. A lot of people will miss that second gunshot wound, whether it be it's in the armpit or it's in some weird spot that you didn't see because you kind of like barely cut the clothes off. You missed it. And now you're like, this guy has another gunshot wound up under his armpit. We didn't. So going back, crap, there's another gunshot wound to the inside of the thigh. I missed that. Let's bandage it up. So going back, looking for those secondary injuries that you may have missed is super important.
Yeah, completely. I spend a lot of time in mine actually just talking about what shock is, and shock is the inability of the body to transfer blood to its tissue, which is perfusion, and just kind of talking about what that does. Do you spend much time talking about what you can really do in case of shock, or just kind of understanding what it is so that they can make educated guesses?
We kind of just talk about like the presentation like you do. Like I will put up a water bottle, and I'll put up 2 water bottles, and then like 4 water bottles. Like, all right, this is how the body reacts. The heart rate increases, the respiratory rate increases. And then, at some point you hit the plateau and then it starts to fall down. Your blood pressure's bottoming out, the respiratory rate starts to slow down, and then the heart rate starts slowing down. So kind of that we're in compensated shock means the body's like, I'm cool, I got this. And then it's like, holy crap, I'm in decompensated shock. I can't fix this. And then you progress down further to irreversible shock, and the body's like, oh, well, see you guys later. I'm out of here.
Yeah.
It's just, it doesn't go down. So we do talk about, if the patient is able to drink water, is alert, can talk and stuff like that, to kind of start giving some water. We're not carrying IV supplies. So, that it's okay to let them drink water.
All right, perfect. So that's circulation. And again, loss of blood leads to hemorrhagic shock. So that's why it's the first thing that we kind of do. We address the massive bleeds, hoping we never get to shock, but I spend that time generally just talking about, how the body reacts to shock and kind of what are those physiological symptoms that we can see, because like you said, that can absolutely help us identify that, oh, you know what, maybe I haven't stopped all the bleeding, and really help find those second or tertiary wounds like you mentioned.
Definitely.
All right. So let's do it again. What does March stand for?
So you've got massive bleeding, and then airway, respiratory, circulation, and then our final one, head injury and heat loss.
The heck are you talking about there?
So this is the one that I aggravate my students and say, look, you have dumped $150 worth of medical supplies on your buddy, and the stupid $2 Mylar blanket is going to cost him his life. You have put a $30 tourniquet on it. You put a $15 pair of chest seals. You've used combat gauze. You've used all this stuff, and it's 70 degrees outside with the wind blowing, and your buddy's core, his body temperature is falling. It's coming 1 degree, then 2 degrees, 3 degrees down. And for every degree that his body is dropping in temperature, his chances of surviving are crashing. So this cheap Mylar blanket that you can unravel and cover up is now what's going to save your buddy's life.
So crazy that just a little space blanket. Those things work. I did a survival weekend thing where we were only allowed to bring 10-pound packs. So a sleeping bag was out of the question. It also happened to be the first night of the year that we dipped down under 40 degrees at night. So we were about 36 degrees. All I had was that thing. The campfire kept popping embers on it, and I would lose about a foot of material every time that happened. But it worked, and I didn't die. So
Nice.
I believe in those things for sure.
Definitely. And it's even for us, like for EMS, like I've been on calls. I'm like, hey, can you give me a blanket? Just a regular like hospital blanket, nice and thick blanket. And they're like, what? Why? It's 90 degrees out here. I'm like, yeah, I still need a blanket. Like, let's cover our patient up.
Yeah.
And so it's something that we forget about. As far as EMS, like, I hate to say this, but we're the world's worst. Like, we'll throw the patient in the back of the truck, and we're like, man, I'm sweating like crazy. And they'll turn the AC on in the truck. You're like, no, don't do that. Like, stop. So, they keep it about 110 degrees in the trauma bay. So if you've ever been in a trauma bay, it's super hot in there. And that's because, they're opening up, looking at this patient, and they do not want them to get hypothermic. They don't want that hypothermic being cooling off the body. They don't want that to happen.
Yeah, definitely. And head injury, these are kind of the two things that we do at the very end. Actually, before we move on, were you done with heat loss, hypothermia?
Yeah.
Okay, so head injury. So why do we diagnose for that? How do we diagnose for that? And why is it important?
That's what I think about as far as head injuries. We've come a long way in concussions and things like that, knowing that there's things that need to be in place for that patient when they get to the hospital. So knowing that maybe, we need to give them some, for me, thinking about using some oxygen, using a BVM, maybe I increase their blood pressure to get perfusion to the brain, things like that. But for civilians, I think about, the altered mental status patient that, they're not making sense. Maybe they're asking repetitive questioning, things like that. So just to be aware of it, that you have someone that you've treated, you put a tourniquet on, but they have a head injury as well. So they're asking repetitive questioning. They don't know where they're at. They don't know who the president is. They don't know what day of the week it is, things like that. So now, like, I teach to disarm the patient, check for knives, check for guns, stuff like that. That way that if they do get combative, that you're able to protect them from hurting themselves.
Yep, totally agree. All right. So anything else there before we kind of wrap up this section and then move on to the rest of the show?
No, I think that's kind of a good, like, I say quick, but that's a good overview of March algorithm. So I think I'm looking forward to diving into each section in upcoming episodes to kind of, really get into the details. But I think that's a good overview.
Yeah, totally agree. Okay, so we'll move into our product segment. And last week we talked about the Soft T, the newer generation of the Soft T. This week you wanted to talk about the Gen 7 cats.
Yeah, like we showed some love to TACMed and Soft T, so now I want to show a little bit of love to North American and the Gen 7 cat. This is my baby. Like, I love it. I've used 6 in the field pre-hospital. Nobody used arm or leg. I actually used one in the field 2 weeks ago, so I was pretty excited about that. But this is probably the most popular tourniquet. It's a polymer plastic one. It has a windlass on it. It's 1.5 inches. It's pretty cool because it has that outer band, but it also has an inner band going in the middle of it. So that's how it actually gets its constriction. Does have Velcro, which sticks to everything, but it's the buckle on it. Like, this is where I think it has the advantage over the soft T. Is the buckle is so easy just to pull through on your off hand, get it super tight, and then turn the windlass until the bleeding stops, and it locks into these wings, and that holds it in place. Now, if you read on the internet, they talk about the braking and stuff like that, and yes, they had a problem in the early days of those windlass braking, but with the modern, Gen 6, Gen 7 cats, they don't break. There's been no reports of those breaking, so that old stigmatism that's attached to the cat is not there.
Yeah, I agree. And the cat is by far my favorite. It's the easiest to put on one-handed. I haven't used the new soft T that I just ordered from you, but for me, it's easy to put on one-handed. It's easy to put on a leg. It's easy to put on an arm. They've improved the buckle, the windlass. Everything works well about it. It's a simple product, and it just works just really well.
And I would caution our listeners to buy from a NAR dealer. Like, don't go on eBay, don't go on Amazon. Even Amazon is sketchy with this. eBay is super sketchy, especially if it says, for whatever reason, like it says veteran-owned company on eBay. I would be willing to bet money that it's a Chinese knockoff.
Yes.
And
go ahead. I'm sorry.
oh, sorry, these Chinese knockoffs, they're cheap. You're like, man, why should I spend $30 with Skinny Medic when I can spend $7 with this eBay dude I've never met, never talked to in my life, but I'm going to save some money? And you go to get it, and basically what you're buying is a toy.
And here's the thing: when I want to buy counterfeit tourniquets to just practice with and things like that, I go to eBay and Amazon because I know that's where I can get them. But if I'm going to carry it, if I'm going to use it, ever for any reason, I only buy from authorized places and people that I trust.
And like, I've broken a bunch in class. The windlass is not strong like it is with the NARCat. The buckle's an issue. Sometimes even I've found that they don't even tighten up. That you go to spin it and it's just, there's nothing tightening up. It just sits there and spins on its own. So there's definitely some problems. And I've seen large EMS services, or I've seen large hospitals buy these Chinese knockoffs because I think they can save money on their budget. And they end up, and I was like, several local to me, I'm like, hey, what are you doing? Like, this is not a NAR. NAR is in our backyard, and you're still buying Chinese knockoffs. Like, stop doing that. So I would really caution people. I've done some videos about how to recognize them. So if you're at a gun show, things like, I was at a Iraq veteran shoot, and this guy was like, hey man, will you take a look at my first aid kit? And I look at it, I'm like, this is a fantastic kit, but this is a Chinese knockoff cat tourniquet. And he was like, no, we had this little discussion. I put it on him at an Iraq veteran shoot, and I broke the windlass right there in front of like a group of 20 people.
Oh man.
So, I mean, I sold a bunch of cats that day.
Yeah.
But they were like, oh, I'll take a cat, please. So, but that's dangerous, especially when your life could depend on it, your buddies, your wife's, your kids. That's another thing too, is they talk about, cats not being good for kids. And to an extent, okay, but the cat will compress down to 5 inches in diameter. Mm-hmm. And we think about 5 inches in our mind, like, all right, that's pretty big. Especially if we don't know how to measure what 5 or 6 inches looks like. So,
and we as guys don't.
We do not know how to measure 6 inches. So if you take a tape measure and roll it to 5 inches and then put in a circle, you're looking at like, man, that's super small.
It's tiny, 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 tiny.
It really is. And I know the soft T, kind of bounce back to the soft T, was put on recently by a Dallas police officer on a 4-year-old and worked.
I saw the video.
So they were super excited about that, which I don't blame them. In my area, the youngest I'd known about was a 7-year-old. So they will compress down small. If it doesn't fit, then the kid probably just needs a pressure bandage because they haven't been eating McDonald's for the last 35 years. Mm-hmm. They don't have the fat. They just need a good pressure bandage. So the cat absolutely will work for kids. It will compress down small enough.
All right, perfect. There's a link in the show notes to Medical Gear Outfitters and their Gen 7 CAT, and you can use coupon code Civilian Medical for a 10% discount. Which brings us to the after action. There's a video, and it actually got you in trouble.
Yes, so I would normally tell you to go look at my Facebook page for this video, but it's no longer there. And as we record this podcast, I am in Facebook jail for 3 days.
Jeez.
And it wasn't even that graphic. Like, that's what got me. I'm like, come on. Like, I have posted way worse stuff, and this one gets popped. It's a lady who apparently crawled over a barrier to it was a leopard, right? Is that what the animal was?
I believe so, yeah.
Yeah. And the leopard swiped at her. And apparently it was the second time this leopard has swiped at somebody. So she's on a roll. But it got her arm, and she is laying down hysterical. There's a guy there trying to help, and he's wearing a Black Rifle Coffee shirt. I thought was pretty cool too. Good for them.
No doubt.
And so, for this one, we don't really see that massive bleeding. We see some fatty tissue, which is good. So all this girl needs is probably a good solid pressure bandage, maybe some Fibodons, maybe in a 4x4, but a pressure bandage, and tell her to stop crying.
Yeah, that's what I was thinking. I was like, a 4x4 pressure bandage, and tell her to quit being a moron. Because she climbed over the barrier, which there's like a few feet in between there, and then the bars on the wire keeping the thing in, or the grid that it forms, is like 6 inches by 6 inches. So it's like huge area. Yeah, she definitely had it coming, but she did not take it well.
No, did not take it well. So she needs, like, for me, like she might need like a My Little Pony bandage. Like My Little Pony, like Minnie Mouse band-aids. I think that's probably what she needed. But it was some great teaching points there. And I read afterwards that she actually went back and apologized to the zoo staff. Like, she got discharged immediately almost, so she was fine. Yeah. And then went back to the zoo and apologized for being stupid.
Yep. Have you seen the product? It's like a zip tie butterfly bandage kind of thing.
I have, but I don't know anybody who's used it in real life.
Me either. And I'm always wondering, like, why would I carry that? Why would I even use that? Like, I'm not in the business of trying to, help people with scarring and close little silly stuff like that. But when I saw this wound, I was like, oh, I wonder if that might work. Like, you can see some subcutaneous fat kind of spilling out of the wound, but I almost wondered, I've never even seen those things in person, so I don't know how big they are, but I thought, well, maybe that might be a decent thing to put on.
Yeah, definitely. That company does a great job with their Facebook marketing, because I've seen it. I get a message about it, but I've never touched it, never seen it in real life, and never known anybody that's used it in real life. But yeah, I think that would be a good choice for that. There again, I think that product has a good chance for like wilderness medicine and stuff like that, but not this video that got me kicked in jail.
Definitely. All right, man. I think that's going to do it for this episode. We are at our time. And again, one more time, what does MARCH stand for?
So we've got massive bleeding, and then we have airway, we have respiratory, circulation, heat loss, and head injuries.
All right, there you go. And then the three phases of care again are direct threat, indirect threat, and evacuation, or care under fire, tactical field care, and tactical evacuation. And those are kind of the three that we're going to be following. Don't forget, if anything happens, make sure you're safe first. Make sure that you're protected from blood, spit, anything else that may happen. Wear gloves. Make sure that the threats, that you've gained the advantage over all of them. And, more importantly than anything, stay safe. And there's a thing you say at the end of every single video. What is that again?
So I always say, you never know when you'll be the first responder. Remember, you need the right gear and the right training.
I love it. That'll do. We'll talk to you guys all next week.
Find us and subscribe at civmedical.com.